It's a cold winter morning in North India. My brief is to talk about rheumatoid arthritis, case-based management. And what I have planned is to first take you through the management of a typical case, enunciate the principles, and then walk you through some case scenarios. Rheumatoid arthritis is the commonest inflammatory polyarthritis that you encounter in clinical practice. It is by no means the commonest joint disease that you come across. That distinction belongs to osteoarthritis. Now, rheumatoid arthritis is a clinical diagnosis. This is a diagnosis that you make on the bedside when a patient presents with bilateral symmetrical inflammatory polyarthritis involving the small joints of the hands and feet with a duration in excess of 6 weeks. And you can appreciate small joint involvement, symmetrical involvement. Almost 20% of the patients are going to be seronegative, and the only way of picking up seronegative rheumatoid arthritis is clinical examination. We do have classification criteria for rheumatoid arthritis, and this includes a scoring system depending upon joint involvement, the serologic investigations that are available, the acute phase reactants, and the duration of synovitis. But for the students, I would like to emphasize that these are criteria for classification, not for diagnosis. The diagnosis of rheumatoid arthritis is clinical, but if you have a study ongoing in which you need to recruit patients for your dissertation or thesis, you need a homogeneous group, and this is where classification criteria are required, and there is a trade-off between sensitivity and specificity. Classification criteria are specific, they are applicable to groups. So if you have a study between Siliguri and between Calcutta and you need a homogeneous patient population, you need classification criteria. But sitting in the OPD, you need criteria that are applicable to individuals, are sensitive, and this is where you fall back upon the robust clinical definition of rheumatoid arthritis: bilateral symmetrical inflammatory polyarthritis involving the small joints of the hands and feet. There are some caveats. One should be reluctant to entertain a diagnosis of rheumatoid arthritis unless hands are affected. Single joint involvement, be very reluctant to give a diagnosis of rheumatoid arthritis. It's a polyarthritis, involvement of 5 or more joints. DIP joint involvement and low back pain are distinctly uncommon in rheumatoid arthritis. And if you have asymmetrical involvement, that should arouse suspicion of psoriatic arthritis or spondyloarthritis. Now, in a typical scenario, people order rheumatoid factor, a test which is widely ordered and equally widely misinterpreted. This is an overrated test. As you can appreciate, apart from rheumatoid arthritis, this is present in several other rheumatic diseases: lupus, Sjogren's, scleroderma. 5% of healthy elderly individuals will show low titer rheumatoid factor positivity. Infections all over the place in our country can trigger RF positivity, and conditions like sarcoidosis, interstitial fibrosis can trigger RF positivity. And that is the reason why it is called the rheumatoid factor and not the RA factor. Rheumatoid factor is not the exclusive preserve of rheumatoid arthritis, and you need clinical correlation. Apart from rheumatoid factor, the other autoantibody that is ordered is anti-CCP. The sensitivity is no more than rheumatoid factor, but the specificity is higher. And do not put a cart before the horse. Order a basic rheumatoid factor first, and if you have reasons, you can order anti-CCPs also. Not every patient with rheumatoid requires the anti-CCP if the diagnosis is clear. So you will get four clinical scenarios, serologic subsets. Some patients will be dual positive, RF positive, CCP positive. Some will be dual negative, which is where you learn to recognize patterns. And I gave you the pattern of rheumatoid arthritis. These are serologically negative, seronegative rheumatoids. And then you can have a scenario where one autoantibody is positive. These serologic subsets do not influence treatment. Your treatment is governed by the clinical diagnosis, not by the serologic subset. As students, you should avoid some pitfalls, and I have enumerated 5 of these. The first pitfall is failing to consider a diagnosis of rheumatoid arthritis when rheumatoid factor is absent. Do not elevate serology to the level of a diagnosis. 20% of your patients would be seronegative. Do not base a diagnosis of rheumatoid arthritis only on serology. It could just be viral hepatitis with joint pains and RF positivity. Be very reluctant to attribute importance to borderline serologic abnormalities. Frequent repetition of rheumatoid factor is a practice that should be discouraged. Disappearance of rheumatoid factor is not the goal of treatment, and do not put the cart before the horse. Do not order anti-CCPs without a basic rheumatoid factor. Now, how do you manage a typical case? The first thing that I have highlighted is that the recognition is clinical. You need a modicum of investigations. Seronegative rheumatoid arthritis, the only way to pick it up is clinical. The game-changing concepts in the last 20 years are dominated by the 20th letter of the English alphabet. We talk about the 6 T's of rheumatoid arthritis: time to treat, treat to target, and last but not the least, the targeted treatments. Time to treat means that rheumatoid is a time critical illness. Early treatment fetches you the best dividends. Treat to target is that subjective impressions have given way to objective measurements. You have indices to measure disease activity, and primarily, rheumatology is not high tech, it is high touch. You count the number of joints and you get a swollen joint count, a tender joint count. You put it into a matrix, you get an index which is called a clinical disease activity index. And that's how you measure disease activity. And the targeted treatments include the biologicals and the JAK inhibitors. Now, in a typical patient, where would you use these 4 agents that are available to us? Anti-inflammatory drugs are invaluable in abrogation of inflammation. The patient comes to you with pain, and to relieve pain, you need anti-inflammatory drugs. Then you have glucocorticoids. The mainstay of treatment are the disease-modifying anti-rheumatic drugs, and in selected situations, you have the targeted treatments. As I mentioned, the mainstay of treatment is the use of synthetic DMARDs, the conventional synthetic DMARDs, and modern day treatment revolves around hydroxychloroquine, methotrexate, leflunomide, sulfasalazine, and you may add to that tiguretimod. The anchor drug is methotrexate. As they say, old is gold and gold is never old. What has not changed is the drug. What has changed is the way we utilize the drug. The starting dose of methotrexate is now 15 milligrams per week. Rapid escalation to the point of disease control or a point of patient intolerance. So you go up to 25-30 milligrams per week, depending upon patient tolerability and response. Should the patient show suboptimal response to oral methotrexate, you will graduate to parenteral methotrexate, subcutaneous or intramuscular, or you split the oral dose. So if the patient is on 20 milligrams of methotrexate, 10 milligrams in the morning, 10 milligrams after dinner on the same day of the week. So if the dose exceeds 15 milligram per week, there are absorption problems and you split the dose. At this point, I would also like to ask all the joinees that if you have questions, please type it out in the chat box, and at the end of the formal presentation, I'll be happy to take up questions. Then we move from dogma to pragma. Folic acid. It actually does not matter whether you give it twice a week, thrice a week, and to simplify matters, you could give it all 7 days of the week, including the day of methotrexate. It actually does not compromise the efficacy of methotrexate, and it's a convention that you omit it on the day of methotrexate. There's nothing like a safe cumulative dose. That dermatology literature of 1.5 grams, that's all gone. You monitor the LFTs and you actually monitor serum albumin and more than cumulative dose. This is very important. Monitoring every 3 to 4 months. Surveillance liver biopsies have almost been given up. What about combination treatment in rheumatoid arthritis? And actually, this is a matter of debate. Most people say that monotherapy is as good as triple therapy, particularly the Western world. You optimally use your methotrexate, and this allows you to achieve a good disease control in 30 to 40% of your patients. The gains with dual therapy or triple therapy can be modest. And in the Western world, they graduate on to the JAK inhibitors and to the biologicals. We in our country do utilize we in our country utilize triple therapy for patients with suboptimal response to methotrexate. And this is something that came closest to being labeled as the panacea for rheumatoid arthritis. The Pudia story, well known to all clinicians. Glucocorticoids, widely used, equally widely abused in the treatment of rheumatic diseases. And these are some examples of what happens when you use these drugs injudiciously. Where should the postgraduate of today use these drugs? And the answer is you need to dichotomize your patients. Early disease has to be dichotomized from established disease. The cutoff is 6 months, and the rationale is different. In early disease, it is used as a bridge therapy to bridge the gap between the institution of disease-modifying drugs and their onset of action. So in a typical scenario, when you start methotrexate, it will take 2 to 3 months to start showing effect. And you bridge this gap with low-dose prednisolone, 5 to 10 milligrams for 6 to 8 weeks. In established disease, more than 6 months old, the rationale is different. You use it during certain situations like disease flare, exacerbations, in pregnancy, in refractory rheumatoid arthritis in order to maintain quality of life, Extra-articular rheumatoid, and I will walk you through some case scenarios. Rheumatoid with ILD, with vasculitis, and then a segment of population where rheumatoid starts after the age of 60, late onset rheumatoid arthritis, where corticosteroids can be invaluable. These are some examples. You can appreciate this person wearing a collar, had atlantoaxial dislocation, wrist drop, digital gangrene, rheumatoid vasculitis. Rheumatoid with scleral melt. This is a lady who needs steroids. Rheumatoid with pyoderma gangrenosum. This needs glucocorticoids. Rheumatoid with interstitial lung disease. So, all patients with rheumatoid arthritis certainly do not need steroids, and those who need steroids do not need it all the time. So, you need to be very judicious with your use. Now, I have spoken to you about anti inflammatory drugs in a typical situation. I have focused on the point that methotrexate is irreplaceable in the management of rheumatoid arthritis. I have told you about the judicious use of glucocorticoids, but what has caught the world of rheumatology with a storm is the targeted treatments where you move from serendipity to specificity. Drugs, designer drugs, which target certain molecules, cells, cytokines, and I am talking of the biologicals and the JAK inhibitors. Concepts are not difficult. You can target the ligand like TNF, and you have this targeting by the monoclonal antibodies like infliximab. You can have a receptor construct which acts as a molecular scavenger. You can target the receptors like tocilizumab. You can target the cells like rituximab. And when the site of action moves indoors, you can use JAK inhibitors. And I can't go into the details, but the concepts are simple. The problem lies in the details. So we have total of 10 biologicals approved for use in rheumatoid arthritis. The ones that are tick marked in the green are available in our country. What do biologicals achieve in rheumatoid arthritis? And are they expensive painkillers? They reduce signs and symptoms, improve physical function, but the icing on the cake is they retard radiologic progression. And if, as students, I have to give you an example, this is like a drug which reduces not only the lipid levels, not only reduces myocardial infarction, but also improves mortality. And in rheumatoid arthritis, the hard endpoint akin to mortality is radiologic damage, erosions. And we were taught that erosions of rheumatoid do not heal, but now the biologicals have shown that erosions of rheumatoid arthritis can heal. And this has been a game changing concept. JAK inhibitors, we have 5 of these agents, 2 are available in our country, and this is the reason why drug selection is important. The conventional synthetic DMARDs number 4, but if you look at targeted treatments, the biologicals and the JAK inhibitors, you have 15, and you need to identify which drug for whom. Should you use tofacitinib for all persons or biologicals for all persons? And the answer is no. The major indication is suboptimal response to conventional synthetic DMARDs. So if you have a patient of rheumatoid arthritis who's responded to your 20 milligrams of methotrexate and is tolerating the drug well, you will not graduate to the targeted treatments. Should the response be suboptimal or there is patient intolerance, unacceptable hair loss, nausea, anticipatory MSs, cytopenias, then of course you need to graduate to alternatives. And the teaching learning point is methotrexate continues to be the DMARD of choice in rheumatoid arthritis. There are several myths about tofacitinib. because many companies now market tofacitinib in India. Are JAK inhibitors biologicals? And the answer is no. They are chemically synthesized drugs, not used, manufactured in living cell systems. They are not biologicals. Are they a substitute for methotrexate? Answer is no. Are they first line drugs? The answer is again an emphatic no. Can you use them without screening? And the answer again is no. You need to screen or before targeted treatments, Hep B, Hep C, latent tuberculosis. Can you combine tofacitinib with biologicals? And the answer is no, because of fear of profound immunosuppression. So I would like to end the first part of my presentation with this key message, that in a typical straightforward situation of rheumatoid arthritis, you start with methotrexate, escalate rapidly. If the patient is controlled on this, continue with this. Suboptimal response, you can combine it with hydroxychloroquine, you can combine it with leflunomide or sulfasalazine. Suboptimal response, move over to the JAK inhibitors, and you can combine JAK inhibitors with methotrexate. And in our country, the biologicals, because of the cost, are reserved for patients who do not respond to these treatments. But this is not a sequence etched on a tablet of stone. If you have reasons to avoid JAK inhibitors, you can use biologicals first. But this is for a resource constrained country like ours. How do you treat rheumatoid flares? Escalations are rapid, de-escalations are gradual. So if you have a 5-year rheumatoid coming to you with a disease flare, you escalate rapidly, but the de-escalations are always slow. And you need to understand the phases of rheumatoid arthritis. First is contain rapidly. Then you have maintain, and maintenance periods are prolonged. Once the person has been in good disease control for 6 months to 1 year, you slowly reduce and then you maintain indefinitely. And the indefinite dosage of methotrexate could be as low as 2.5 or 5 milligrams per week. The controlling dose may be 20 milligrams. But 2 years down the line, if the patient is in sustained remission, you could be on 2.5 milligrams a week. What should you refrain from doing? Repeating rheumatoid factor at every visit. And then, of course, I'm not sure about Calcutta, but in Delhi, these panels of tests are the flavor of the season. People will come carrying a report of RF positivity. They get it done as a part of 100 tests done by these companies or labs, and an RF report is positive. Should a patient be clinically quiet, bereft of symptoms, do not intervene. Such patients need observation, not intervention. Do not treat the serology, treat your patient. Now, this was the mandate to me by the ICP. My dear friend, Dr. Sarkar, Dr. Ganguly, they wanted a case scenario based discussion. Having iterated the principles of managing rheumatoid arthritis, now I will take up with you, I'll walk you through these 6 scenarios. What do you do in a patient of rheumatoid arthritis who has a single joint that refuses to behave? Knee pain in rheumatoid arthritis, pregnancy, many of these are young women, ILD, an important extra-articular complication, CKD and liver disease, important comorbidities, and I would also briefly touch upon D2T, difficult to treat rheumatoid arthritis, and what should you do when you get a consult from your colleagues about surgery. Single joint involvement, and these are two examples. Single joint involvement, this lady had this third PIP. This is another patient, not the same patient. And they had a single joint involvement. The Disease was globally well controlled. So rather than escalating treatment, you will inject these joints with corticosteroids. Do not escalate systemic treatment. Disabling knee pain. And this is not uncommon. And as you can see, this is a valgus deformity. And how do you look at the X-ray and decide that this is not age-related osteoarthritis and this is secondary osteoarthritis? Subchondral sclerosis, so very prominent in age-related osteoarthritis, is missing. Medial compartment disease, the hallmark of age-related osteoarthritis, and this is a pan-compartmental disease, and there is periarticular osteopenia rather than subchondral sclerosis, and instead of the varus, you get the valgus. So this is rheumatoid with osteoarthritis of the knees, and this is, as you can appreciate, primary osteoarthritis. Medial compartment is more affected, and you can see subchondral sclerosis. So looking at the X-ray, you can get some idea whether it is primary or secondary. And in such a situation, you can use intra-articular steroids. But if the joint damage is more, it's bone upon bone, then you need surgery. Second scenario, many of these are young women, some married without children, some with one child wanting another child, and some could be unmarried. So, how do you tackle that? The drugs that are checkmarked in the green are compatible with pregnancy and breastfeeding: hydroxychloroquine and sulfasalazine. Leflunomide and methotrexate are a big no. You stop methotrexate about 3 months, and now the current guidelines say 1 month is sufficient before pregnancy. Leflunomide is mentioned about 2 years before planned pregnancy. Methotrexate does not affect fertility. And this is what you need to. Sometimes the family physician says, oh, you are on methotrexate. So this does not actually, in the dosages that we use, it does not affect fertility either in men or in women. The paternal exposure is allowed. So for men wishing to father a child, and this has been a paradigm change. When we were students, we used to ask men from to desist from fathering a child, and we applied the same principle. Now, paternal exposure of methotrexate and leflunomide is allowed. What about anti-inflammatory drugs? All of you are aware about the premature closure of PDA, patent ductus arteriosus. So avoid it in the third trimester. Use short-acting like ibuprofen. What about tofacitinib and baricitinib? They have a short half-life. So stop these 4 weeks before planned conception. Paternal exposure, now data is coming, is that they are permitted, and you should avoid these during breastfeeding. What about biologicals? They are compatible with pregnancy and breastfeeding. So if you have a difficult rheumatoid, not getting better with sulfasalazine, hydroxychloroquine, or low dose steroids, then you can use anti-TNFs, which allow pregnancy and breastfeeding. Other drugs permitted during pregnancy: low dose steroids, azathioprine, cyclosporin, and this is more important for lupus. We don't use these drugs so much in rheumatoid arthritis, and anti-TNFs. Drugs compatible with breastfeeding: I have listed prednisolone, hydroxychloroquine, sulfasalazine, azathioprine. The big boys, the anti-TNFs, don't cross into the breast milk, are allowed. So the case scenario that I would now like to spend some time upon is rheumatoid ILD. And this is one example. So rheumatoid is a systemic disease. And these is another example. So joints dominate the clinical picture, but don't forget the other organs. The prevalence is quite variable depending upon what modality that you use. Symptoms are non-productive cough, shortness of breath, and fever and chest pain are less common. And these are the differential diagnoses. And as students of internal medicine, you know that you need to look at infection, heart failure, reflux, and radiological patterns. The commonest type is UIP. Based upon a CT, you can get this. But what the point that I would like to tell here is the mere detection of a few crepitations at the basis does not mean that you will go all out to treat RAILD. Not every patient with a radiologic evidence of HRCT showing some ground glassing needs aggressive treatment. Symptomatic patients with RAILD need treatment, and those with progressive respiratory impairment. So the key words are symptomatic patients and those where the disease is progressive. And this concept is coming up in the pulmonology literature. So clearly, patients who are symptomatic will need treatment. If there is a physiological decline in the forced vital capacity or DLCO or radiologic evidence of disease progression, so identify patients who need treatment. And this is an important slide. It mentions the autoimmune ILDs, and it is only the shaded portion of patients who progress. So the mere detection of ground glassing on HRCT does not mean that you will be aggressive about treatment, and not all patients with ground glassing will progress. So you need to monitor your patients. And I have shown here that you need to identify patients who are progressive. And this concept is now firmly entrenched in pulmonology literature. And we in rheumatology are also beginning to realize that radiological detection can be there. A few ground glassing appearance and some interstitial thickening can be there. But if the patient is symptom free, PFTs are maintained, go slow on your immunosuppression. Busting some myths, methotrexate does not cause RAILD, and most pulmonology colleagues now have come around to this view. It may actually be protective. How do you treat RAILD? You use steroids, half a milligram per kg body weight, and you use other drugs like azathioprine, mycophenolate, mofetil, and in progressive disease, cyclophosphamide or Ritux. Where you have fibrosing disease, there you add nintedanib and pirfenidone. Methotrexate-induced lung injury, well known but uncommon, subacute process. So methotrexate causes hypersensitivity pneumonitis, does not cause ILD, and eosinophilia is a characteristic feature, and most cases occur within the first 6 months of methotrexate institution. The next case scenario that I would like to talk about is elevated aminotransferases. And these could be due to hepatitis, don't forget ethanol, and in our country, metabolic dysfunction associated steatotic liver disease. I mean, this has undergone many name changes. The fatty liver of good old days, now MAFLD, MASLD, and CHF can cause that. And then, of course, don't forget anti inflammatory drugs. They are an important cause of aminotransferase elevation. Don't jump to the conclusion that it is methotrexate causing that all the while. In such a situation, use hydroxychloroquine, sulfasalazine, cyclosporin, anti-TNFs can be used, and you can reduce the dose of methotrexate, leflunomide, and JAK inhibitors. And this is an algorithm employed before starting anti-TNFs and JAK inhibitors and all biologicals. As students of medicine, you know that screen with HBsAg, anti-HB core antigen, then you also anti-HBs. Those who are positive should be given before targeted treatments and antivirals. HBsAg negative, anti-HB core positive, look at the DNA levels. And in such situations, sometimes with concomitant hepatitis B, you need to treat rheumatoid arthritis. and prophylactic antiviral treatment is given. And this is again that you are all aware of. Even when you have low HBV DNA levels, sometimes people would add antivirals when they are using targeted treatments. Hepatitis B and rheumatoid arthritis. I have mentioned here that you must involve a hepatology colleague. Even patients who have to receive doses of steroids more than 10 milligram for more than 4 weeks are at a high risk for HPV reactivation, and the highest risk is with rituximab. Sometimes you have bad rheumatoid, you have ongoing hepatitis, and there you have to individualize your treatment and you need to consult with your hepatology gastroenterology colleagues. Rheumatoid with CKD, anti-inflammatory drugs are contraindicated. Leflunomide is the go-to drug, can be used without modification. You need to reduce dosages of methotrexate. Hydroxychloroquine sulfasalazine also reduce dose. And upadacitinib, which is not available in our country, needs no dose reduction. Proteinuria in rheumatoid arthritis, be aware of amyloidosis. In the olden days, when we used gold and deep penicillamine, we encountered this. I haven't used gold for almost 25 years now. CTD overlap, don't forget that comorbidities, diabetes, hypertension could be responsible or it could be unrelated. You need a biopsy. What about the consults that you get? A patient of rheumatoid arthritis pre-op clearance. Steroids do not stop abruptly. The disease modifying drugs like methotrexate actually can continue. You can even ask the patient to go in for a joint replacement. People don't stop it. Biologicals depends upon half-life. With etanercept, where the half-life is less, you stop it 2 to 3 weeks before. Retux has to be several months before elective surgery. JAK inhibitors hold 3 days before surgery, resume after the surgical wound has healed. The last but not the least case scenario, refractory rheumatoid arthritis, the definition varies. In the West, people label patients as D2T after they have failed several biologicals. In our country, where the biological penetration is low, if a patient has failed a combination of conventional synthetic DMARDs and low dose steroids, we call it refractory. Before you call it refractory, make sure that your diagnosis is correct. You are not dealing with a disease like psoriatic arthritis. Check adherence. Drugs will work only if patients take them. Judicious use of corticosteroids is invaluable. Graduate to parenteral methotrexate, hydroxychloroquine, leflunomide, and if it's a true refractory rheumatoid, biologicals or JAK inhibitors. Friends, I would like to end the formal presentation here by mentioning that rheumatoid arthritis is a clinical diagnosis. Don't get swayed by rheumatoid factor in isolation. Early treatment fetches the best evidence, and you now measure and treat. The core treatment principles revolve around early use of methotrexate, graduating to parenteral methotrexate when you have suboptimal response with oral methotrexate. You learn to use an important weapon in your arsenal, glucocorticoids, and the difference between an experienced rheumatologist and an inexperienced doctor is when and how to use glucocorticoids. The targeted treatments represent a major advance. And finally, ensuring adherence in chronic diseases like rheumatoid arthritis is as much an art as it is science. Thank you very much for your kind attention, and I would be happy to take up questions as permitted by Dr. Ganguly and Dr. Sarkar.
Thank you, Rohini. That was a Excellent. As usual, your very lucid presentation. And I will request all our PGTs and other colleagues to please go through these two books which I have read. The chapters are very well and written and are very informative. Now, Dr. Ganguly, are you there?
Yes. I want to
Yeah.
ask Rohini one question. That recently
No,
I saw a patient of young lady. I also told this case to Professor Arun Sarkar. Presented patient young ladies of adenocarcinoma lung, presented with features of like adenocarcinoma and pleural liquefaction having high titer of anti-CCP, misdiagnosed and treated as rheumatoid arthritis. So please mention the cases which may have high anti-CCP titer but not rheumatoid arthritis.
This is certainly well known. Tuberculosis is one situation, and as you are mentioning, malignancy also. And
even
some of
leprosy
these,
also. In leprosy also, anti-CCP may be
yes, well
present.
taken, infections, and that is why I never interpret serology in isolation. And some of these patients, if you give them time, may develop rheumatoid arthritis later. Actually, what happens is that in some people, serology can be a bystander, and in others, it may herald rheumatoid arthritis after 4 years, 5 years, we do not know. So that is why serology should never be interpreted in isolation, and we should not jump to treat the serology. Very well taken, sir, that no matter what you say and do, one the thumb rule in rheumatology is don't chase the serology, correlate clinically and treat the patient.
পিছনে গাড়ি দাঁড়িয়ে গেল চলো চলো চলো
Then
নিজেকে
we
ফলাও না
have
করলে
some questions
Now
in the chat box.
you
Sir,
can
with
see
your
the
permission,
chat
can
box.
I answer?
Yeah. Please.
The first question is early institution of hydroxychloroquine can decrease the cardiovascular mortality and morbidity. Actually, it's a sweeping statement. Hydroxychloroquine has multiple uses, lowers the cholesterol levels, lower sugar levels, has some benefits on mortality, but you have to nuance it with the pill burden. So if a patient is diabetic, has dyslipidemia, has rheumatoid arthritis with osteoarthritis of knees, so you have to balance it. Primary use for cardiovascular mortality, the cardiologists don't use it. So I would say that if your rheumatoid needs it, use it. And is JAK2 inhibition better in patients of rheumatoid with lung involvement? And the answer is no. You continue with your methotrexate and you use steroids. Should you need other drugs, then mycophenolate mofetil, cyclophosphamide, and rituximab. JAK inhibitors are the same as methotrexate. Should we replace methotrexate with JAK2 inhibitors in ILD after prolonged methotrexate? And I have debunked that. You see, methotrexate used in psoriasis. Psoriasis doesn't cause, you don't get ILD. So it's the disease that causes ILD. Methotrexate does not cause ILD. But if you have some reasons, like where you are finding that the patient is not tolerating, there are cytopenias, infections are going up fine, but otherwise, the blanket replacement of methotrexate by JAK2 inhibitors in every patient of rheumatoid ILD is not mentioned by any guideline. Is there any specific indication of leflunomide? The number one indication is intolerance to methotrexate, where you use leflunomide because 50% of people with methotrexate will have to give up the drug after 5 to 7 years because of nausea, emesis, hair loss. The second indication is suboptimal control with methotrexate alone, where you add it on. The third indication of leflunomide is chronic kidney disease, where with high creatinine. So these are the three important clinical indications of leflunomide. Iguratibod is a drug that where you have difficult to treat rheumatoid, you are not able to manage it. The disease modification data with iguratimod is not very robust. That's why it's not available in the West. Then we have questions and answers. This is by Bodhibrata Banerjee. Important question. If we were to give rituximab to a patient of difficult to treat RA, I think serology is important. And the answer is it works, they say, better in seropositive patients, but it does also work in seronegative patients. The importance of rituximab is that the cost is much lower for the patient. So one would really, try to, it's a very important point, which biological for whom. So the importance of rituximab is now with biosimilars, 1 gram you can get for 14,000 rupees or so. Some of the governments provide rituximab. So serology is not the only deciding, it's not a make or break situation. Let me put it like that. Then we have there is an autoinflammatory phenotype of rheumatoid, which is called seronegative rheumatoid arthritis. Now, this is a very insightful question by Bodhibrata Banerjee. Autoinflammatory and autoimmune are
একটু
two
পরে ফোন করো,
different
একটা মিটিং
sides.
চলছে
Where
আধ
the
ঘন্টা।
innate immunity is affected, you call it autoinflammatory. I would not call seronegative rheumatoid as autoinflammatory. I would still call it autoimmune, but this is a hypothesis, and I think for your PhD, you can work on it. It's a very insightful question, but I refuse to get trapped into that, and I would not call seronegative rheumatoid as autoinflammatory and not autoimmune.
I would like to add one more because this negative seropositive thing, we know only about two things, that is IgM and anti-CCP. In future, there may be more serological marker. So you cannot
100%.
say
100%. And what is your opinion regarding this subset with respect to outcome and extra-articular manifestation? Seronegative rheumatoid arthritis is a label that you should always be open to revision. Some of them land up with psoriatic skin patch after years. Some of them get ILDs indistinguishable from seropositive rheumatoid arthritis. Sometimes the serologies become positive after 2 years. So all of us have encountered seronegative situations, but I over time have now started calling it seronegative arthritis rather than seronegative RA, which gives me some liberty to change the label down the line and also frequently examine the patient.
or you can call it inflammatory polyarthritis.
Yeah, seronegative
Broad term.
inflammatory polyarthritis, SNIA, that whatever you choose to call it, then is again a very
মিটিং চলছে,
insightful
পরে ফোন
question
করছি 10 মিনিটে, হ্যাঁ
by
মিটিং।
Dr. Banerjee. Is anti-HBC antibody needed for all biologic or only for retux? Actually, as a purist, the gastroenterologists ask for everyone before targeted treatments. I mentioned that. Sometimes, because of cost, I do not ask for everyone, and you need to individualize. The best is the enemy of good. If you make the screening so expensive for the patient, I mean, it's like vaccination. You want to give Shingrix, you want to give Previnar, you want to give influenza vaccine. So दवा से ज्यादा तो वैक्सीन महंगी पड़ जाएगी. I don't think there can be answers, and which is what medicine is as much an art as it is science. So actually, the technical answer is ideally yes. Habibur Rahman is now asking about after how many days of methotrexate continuation we determine whether methotrexate is adequately controlling disease activity. 3 months is a good enough time. At 3 months, you should assess. Then Vivek Sood is kindly consider a few points on cytopenias. What happens is that with cytopenias, some degree of thrombocytopenia, leukopenia can happen. When you have significant cytopenias, rule out lupus overlap. Some of these patients may have lupus and they may have thrombocytopenia. And then, of course, you have the well known Felty syndrome, which is uncommon these days. You learn to skirt with what are kind of reasonable cytopenias. So platelet counts of say 1 lakh 90,000. If the trend is the same, more than a isolated reading, if the trend is the same, I would not rush to stop all DMARDs. Same goes for TLCs. Some of these patients will hover around 3,000. Their ANCs will be more than 1,500. So you need to individualize treatment. Significant cytopenias, or if there is a patient where you think medical legal issues could come up, you need to hold the drugs, you need to repeat the counts. If you demonstrate that they are going up and on reinstitution they are going down, then you need to change the drug. Again, this is something, but minor degrees of cytopenias, you have to accept it with these drugs. Then Tamoji Day in a patient with rheumatoid arthritis newly diagnosed. When should we order HRCT? Very, very important question to look for ILD. You don't look for ILD asking for HRCT. There is no guideline which says that year one ask for HRCT, year two ask for echo. Absolutely not. If the patient has cough, if the patient is symptomatic, and then you have no better explanation for cough or dyspnea, you ask for a HRCT. It is the gold standard for picking up ILD, but first you should have no better explanation before you order. Subjecting every patient at a point of time is not recommended. Bone mineral density is the same way. If you have reasons to use long term steroids, if the patient is postmenopausal or there are reasons, so you ask for these. So don't order HRCTs unless you have cogent reasons. Then we have Bodhibrata Banerjee, who's has some questions which I must say out of the box thinking, who's thanking ICP Forum and the speaker. Thank you very much. And then we have Somadeep Rakshit. Can we order a test for rheumatoid factor in a case of inflammatory polyarthritis less than 6 weeks? And should we treat like Somadeep? This 6 weeks is a very robust definition. And the idea of 6 weeks in the olden criteria was that you kind of differentiated viral arthritis, which are self-limited, from rheumatoid arthritis, and then went on to order serology. The 2009 or 10 classification criteria have done away with this. They say that if you have more than 6 weeks, you allocate 1 point. Less than 6 weeks, you allocate 0 point. So technically, you could ask a patient on day one, and if the patient has 10 swollen joints, and acute phase reactants are high, rheumatoid factor is more than 3 times the normal, your scores will match up to more than 6 by 10, and you can certainly call it rheumatoid arthritis. So this is a practical definition so that you don't ask everyone to spend money. If you have a suggestive feature, you can order it on day one. And if the patient is rheumatoid factor positive and has inflammatory polyarthritis, you can call it rheumatoid arthritis from day one. That is what the classification criteria talk about. You have to use your clinical judgment. Clinical definition is, and as you said, they have allocated 1 point for 6 weeks in the classification criteria. So you have to see the situation, circumstances. If every person with joint pains has to be ordered a rheumatoid factor, that is a practice we discourage. If you are suspecting rheumatoid, go ahead. Then there is a question from Somadeep on can we start methotrexate in a patient of anemia with HB less than 9? And the answer is, I think yes, because you could have anemia of chronic disease. And if you have iron deficiency, you could uh, correct the iron. And if you have a patient of thalassemia, which at least in North India, in the Punjabi population is 7-8% thalassemia minor, their hemoglobins will be low. And can we use methotrexate in a patient of B12 deficiency? I don't think there are any specific things about not using it. You need to identify the cause of anemia, treat it. If the hemoglobin levels are very low, less than 5, 6, it would be prudent to hold methotrexate till you identify what is happening. Rheumatoid arthritis and malignancy, which DMARDs, biologicals and traditional synthetic DMARDs can be used. Actually, it depends upon the type of malignancy. Past history of hematologic malignancy, Ritux can be used. That is recommended. Like if somebody has been treated for lymphoma, leukemia, you can use a well-controlled malignancy in the past, well-treated, you can use any of the DMARDs. Tofacitinib, there are some concerns about malignancy, and again, you need to individualize this treatment. Then there is an anonymous attendee. Suboptimal response to methotrexate, should we add TOFA or HCQ and sulfasalazine? Again, it depends upon the pill burden with hydroxychloroquine and sulfasalazine is more. So you may add tofacitinib, but you need to screen your patients before tofacitinib. And if there is risk of herpes zoster or coronary artery disease, or the patient could have a background risk of venous thrombosis, clotting, I would prefer hydroxychloroquine and sulfasalazine. And patient selection, you need to look at 360 degrees before deciding. RA and amyloid, what drugs are used? You need to treat your rheumatoid arthritis effectively. So you need to be aggressive with your treatment. IL-6 inhibitors, anti-TNFs, Ritux, they could be used. How common is RA-related autoimmune hemolytic anemia? Well, this is a factual question. I cannot give you the numbers, but I can tell you as a clinician, AIHA I get to encounter with lupus. I don't get to see it so very often with rheumatoid arthritis. ITP-like picture, AIHAs we get with lupus, and lupus overlap with rheumatoid arthritis is not uncommon. And some of these lupus patients have been labeled as rheumatoid arthritis because they are RF positive. So if I have this kind of a DCT positive autoimmune hemolytic anemia, thrombocytopenia, I would carefully rule out lupus. Then we have in a patient with RA, vasculitis, ILD, getting treatment with methotrexate, HCQS, rituximab is MMF necessary. Well, you see, for ILD, if you are using Ritux, then you don't need MMF. But if your Ritux period has been more than 6 months, the effect has worn off, and you need a maintenance treatment, Ritux effect does not last forever. So after 4 to 6 months, you will need an anchor drug. There you would use MMF. So combination of Ritux and MMF, unless it is a very progressive fulminant disease, answer is no. I think I have taken up all the questions in this chat box. Then I have come to the end of these questions.
Okay, Dr. Handa, your opinion regarding the hydroxychloroquine. I think rheumatologists are using less and less in rheumatoid hydroxychloroquine.
Absolutely
What is
well
your
taken, sir, because the type of rheumatoids that you and I see are patients who have not the so-called community phenotype. there is described a community phenotype, mild rheumatoid, occasional pains and aches, ESR is not very high, non-erosive. Those people qualify for hydroxychloroquine. Where you have a robust serology, high CCPs, high rheumatoid factor, more likelihood of erosion, as a single drug, virtually no. So, except for the mildest of mild phenotypes, most people would use methotrexate. And of course, you could start with 15 and maintain down the line on 7.5 or 10 milligrams.
And some patients are palindromic. What about those patients?
Well, palindromic, I have a very simple way of handling it. That palindromic, if the attacks are few and far between, treat the attack with anti-inflammatory drugs. If the attacks are frequent, if they are troublesome, if they are severe, and if the good days are less, the bad days are more, treat it like rheumatoid arthritis. So anything which is frequent, troublesome, compromises activities of daily living, with bad days outnumbering good days, you treat it like rheumatoid. And it's a matter of for each person, there is no description of attacks will mean 3 attacks in a month or 5 attacks in a 6 month period. So it is a eyeballing summative impression you discuss with the patient. अगर वो दुखी है, there is no point in pussyfooting about by using this. But if the attack comes once in 6 months, treat it with NSAIDs and with low dose steroids. Treat the attack. But if the attacks are more and the patient's quality of life is disturbed, you treat it like rheumatoid. It's a phenotypic description of a type.
Yeah. Okay, so I think we have exhausted all the questions. No, there are no more questions. So we should call it a day. Thank you, Professor Handa, for your nice deliberation. And I also thank all our participants. And we'll have our next meeting. We'll be meeting. Are you coming to Epicon,
Yes,
Dr.
I
Handa?
come, I look for